My name is Dylan Scott. I am a senior correspondent and editor at Vox.com, and I'll be here moderating our discussion today with our illustrious panel. I wanted to just one quick housekeeping item. If you want to scan the QR code you may see around the room, or if you have the app for the conference, you're able to submit questions that way, and they'll come into the iPad that's up here at the front, and I am definitely going to try to reserve some time at the end of the panel to go through your questions and try to pose some of them to the panelists here. So I thought I would just quickly myself introduce the folks we've got up here and then just get straight into the conversation. Immediately here to my left is Karen Knudsen, the outgoing CEO of the American Cancer Society. We have Harlan Levine here. He is the President of Health Innovation and Policy at City of Hope. Next to him is Mohit Manrao, He is the Senior Vice President and Head of Oncology at AstraZeneca. We have Kimran Rathmel. She is the Director of the National Cancer Institute. And then lastly, we have Amir Ali Talazaz, who is the co-founder and co-CEO of Guardant Health. So yeah, they're here. We are here, as you well know, hopefully, to talk about the increase in early onset cancer among some of the younger generations, a topic I have written about and that is selfishly of great interest to me as a young person. So yeah, I thought we would get into it, and I thought I would start with you, Karen. I know that there's, I think, been a recent ASC study about the increase in incidence of early onset cancer that found particularly there was an increase in 17 of the 34 cancers that you all studied. And one thing that in particular stuck out to me about that study was some of those increases were among cancers that had previously been declining, which is not the trend line that you want to see. So what does that tell you? What is the story that you see in that data?
Yeah, so this is an ongoing set of observations that we have been following over the years. You know, every year, the American Cancer Society, our internal science teams run a large research study looking in every zip code across the country, every demographic and geographic, to look at cancer trends in incidence and mortality. And there had been this trend in even high-frequency cancers like colorectal cancer of increasing frequency of diagnosis in people we would not normally have thought of as being susceptible to that cancer type. Colorectal cancer really being that canary in the coal mine. So much so that we were the first to use evidence to reduce the recommended screening age for first colonoscopy to age 45 from age 50. And then 2 years later, the U.S. Prevention Services Task Force followed us. Similar types of observations in breast cancer, where now the recommendation is to have that first discussion with providers at age 40, and then everyone starting mammography at age 45, again, for women of average risk. But seeing these trends, there was the thought to put together a very large study to look at different generations. So it was a study of 24 million people, so not small, comparing baby boomers to Gen X and millennials. And what we saw in the following the periods from 2000 to 2020, so 2-decade assessment, is that there were, of 34 major cancer types that we followed, 17 were on the rise, significantly so, sometimes 2 to 3 times the rate in millennials and Gen X versus baby boomers. So clearly something is different. And when we have these discussions, there's always the thought of, well, it's obesity, because this is going in line with the rise in obesity in the United States. And that's probably true and unrelated, because of those 17 cancers that are on the rise, only 10 of them are actually related to obesity as a risk factor. So there must be something more. And I think that's one of the things we'll probably hit on right in this panel, is what really could that be? But to our knowledge, this is one of the largest studies really documenting that there's truly something different that's happening in millennials and Gen Xers versus baby boomers. And to your point, some of those cancers are actually at the same time going up in the younger generations, going down in the 65 and older population, so something quite different.
Well, I wanted to take this question to you, Kimran. You know, as in your role, obviously, you sort of have the ultimate responsibility to try to answer this question of why is this happening. So, how do we? My question first is, how do we go about trying to answer that question? And I know that you all have some fresh data on lung and colorectal cancers among younger patients. What have you found?
Yeah, so very similar to what Karen said. This is a trend that's been. It's important to us that it's become more visible in the public, but it's been very visible to our scientists for a while, and paying attention is where we need to make some difference. I think this is where science can make a big impact. So, you know, the big question is always why. You know, when I meet a patient, they always want to know why them. When we look at a group like this, we want to know why. I agree completely with Karen that when we look at the spectrum of cancers that are on the rise, it's not every cancer, but it's a lot of them, and they're rising in different ways. So we really need to look at this critically. We need to understand the variation so that we can begin to understand which parts are related to obesity, diet, and exercise, which ones are more related to sun exposure, smoking, alcohol, the risk factors that are well known to us, but may have a variation in how they're being consumed or exposed in younger people today, as well as the many other things that people are exposed to today that prior generations weren't. So taking a scientific approach is where we'll be able to do this. And the thing that I think about early onset cancers, where there's incredible opportunity, is that just like when we look at the exceptional responders, we know that there are factors that we can learn that are relevant to the greater group of cancers. These are an exceptional group because of the age at which they acquired their cancers. And so the things that we learn will apply so broadly. So I'm really excited for the kinds of science that will come out of being intentionally focused here.
One more question for you, Karen, or you, Kimran, or both. You know, you made this point, Karen, that, you know, it used to be obesity was sort of, and diet and exercise was sort of the first and foremost risk factor that people thought of for these diseases in particular. But I know that there's been a lot, I mean, I feel like a lot of conversation is happening right now around alcohol, the role of alcohol, around, you hear things about like microplastics, ultra-processed foods. I wanted to get a current sense of like, what is our level of understanding about how those sort of new risk factors are contributing to what we're seeing?
Yeah, it's a great question. And one of the ways, I totally agree with Kimran that this is an opportunity for us to use science to understand the why. How do you do that? So in the cancer risk world, you do what's called a cohort study, where you follow healthy individuals over their lifetime and collect as much data as they're willing to give. This is something that ACS has done since the 1950s, but has also been a massive endeavor for the National Cancer Institute. So the things you talked about that we take for granted that we know now, obesity, alcohol, for example, 2 major risk factors for breast cancer, add sedentary lifestyle to a whole host of cancers as well. We know from things like cohort studies. Unfortunately, if you think about how you do those, it takes quite a while for those to play out. So the things that Gen Xers and millennials were exposed to, it's going to take us some time to really understand through science what those really look like. But what I would emphasize, even though we don't know, there's this big question, what are the other drivers? There are things that we can build on what we do know. And by our own estimate, if we can just get people to take up the prevention measures that we know about right now, then we can further reduce the cancer mortality rate by another 20 to 30%. These numbers are huge. So I wouldn't want people to take away that it's rising in younger individuals. We don't know why, so we don't know how to stop it. The same risk factors still apply. It's just that there's something more. So the things that people can do are quite actionable. Don't smoke, reduce alcohol, stay healthy in terms of an active lifestyle, have a healthy diet, low in red meat, high in fibers and fruits, all the things your mothers and fathers told you. But the other thing, which we always try to emphasize at ACS as well, is you have to move. So it's not enough to be thin and have a good diet, actually. You really have to be physically active. It's an important component as well.
Yeah, agree. I'm going to add one other thing that I think we will learn a lot more about as we study this group of patients is we're really focused on environmental and lifestyle risk factors, but there will likely be things we learn about genetic risk factors as well. I'll just share an anecdote of a patient that I just met. She's a marathon runner and ran the New York Marathon, and she is a breast cancer survivor, 30 or so years old. And because of her breast cancer, with not a big family history, but there was some enough to do some genetic testing, and so she has a low risk gene for breast cancer. So now all of her sisters, all of her cousins are going to be tested, and that may actually seemingly increase these numbers, but will save lives, right? So we will learn more about who's really at risk so that people can know what they need to do to mitigate their risk.
Yeah. Well, Harlan, I want to bring you in at this point in the conversation because you come at this from, a provider perspective and, sort of the most patient-facing among us, perhaps. And so I wanted to ask about patient awareness and screening. Like, what's your sense of, are we getting better at catching these cases early? And given that these are the people who are probably, and I think of myself in this regard, probably least likely to be attentive to things like cancer screenings, like, do people even know this trend is happening and they should be paying closer attention?
So I think that people are aware that the trend is happening because it's been in the news the last few months, but I don't know if it's really absorbed or sunk into our society. So I don't sense a lot of change in behavior out across the country. Let's step back a little bit though and talk about screening in general. We know that things like colonoscopy and mammography are important for screening for 2 of the cancers, but they're vastly underutilized. Fewer than half the people in the country get colonoscopy who are eligible for colonoscopy. And these are people, we should just be clear, people who are older are still at higher risk than this young population. In fact, the overall rates of cancer, as Karen said, even in aggregate, they are still coming down. There's just this young group that's accelerating quickly. But we really haven't been successful at screening in the older population. And I think the reason why I mentioned the numbers, I think it's going to be harder in a younger population. Number one, they feel invulnerable. Number two, the risk is still pretty low in the general young population. So if you just apply a lot of the same screening methods to these folks, the yield is going to be low if you do it across the population, which runs the risk of people just, by the time they get older, kind of shrugging their shoulders and saying, well, I've been doing this for 10 years. Why do I keep doing it? So I really do think we need to be more strategic about this younger population. And I just want to point out to the group that, and Karen, correct me if I got this wrong, but the work that you did helped to move the age of colonoscopy down to 45. That was based on years of study. What we're seeing now, an increase in colon cancer, is not this massive increase in 40-year-olds. It's actually happening at 30-year-olds.
That's right.
Yeah.
So well below that 45.
Yeah. So this is a different type of trend that we started to get hints about when I was in. Okay, I'm old enough, not in med school, but in practice at some point.
5 years ago.
Yeah, a few years ago. So I don't think we have the right approach yet to screening. Specifically, areas that I think would help, number one, is let's address early on the disparities we already see in cancer screening. We're not doing a good job of getting the message out into the areas that aren't directly next to an academic center. So at City of Hope, we recognize this. So we've actually invested in a mobile van that will go into underrepresented areas and not just do the mammography that we can do on the van, but actually bring people in and talk about the importance of prevention and other screenings that we can do. But also family health clinics need to get more involved. So I would have to, number one, I would say let's get communication, education out in the community. Let's make it culturally sensitive. I'll give you an example that I think most of the people in the audience know about. We're all pushing to get HPV vaccines for people. And somehow or another, that in some areas the message is about reducing sexually transmitted disease or reducing infection. this is about cancer prevention. And I think you need to message it correctly to get people's attention. So that's the other area. And then just very quickly, because I'm sure you have other questions you want to get to. We need to develop something called precision early detection. What we do across the entire youth population is it's not going to work because the numbers are so small. We have to do a better job of assessing the risk of that population, whether it's genetic testing or some of the newer techniques that maybe we could talk about later in the hour.
Well, I wanted to bring
Dylan,
it.
if I may add, I think I fully agree with what Dr. Holland said. I think there are three aspects. One is, if we see screening rates today, in certain places we have done very well, but in certain areas we haven't. So we have to learn why mammography we could drive quite a lot versus lung screening that is not happening, or colorectal screening that is still not to the point where 1 in 3 eligible are not even going through that screening, right? We got to understand those barriers, solve for those. But at the same time, we also start to look at these younger populations who don't have access to those screenings. And there is a societal element that we need to involve everybody, like in this room, to be aware of what the risk factors are, what they need to be taking action on from what we know today, that they can change in their behaviors, but also really working on how we can make that screening accessible to them in the parallel while learning why it didn't happen. And the last thing I'll say is, we got to ride the technology wave and see what are the better screening options that we can bring, whether it is blood-based. So if I go back, and many others, but if I go back, heart disease was such a big thing, or diabetes was such a big thing when it started with blood testing that you could get your HbA1c, at a population level, you could start seeing that being controlled early. Like if we can bring in cancer screening that happens in your, regular physical annually with a 10 mil draw, it can transform. Now, it has other problems that we need to deal with, but it can transform care. But similarly, working with data sets that we have, in the Genetic Nature publication, we just published a tool we call Milken, which looked at detecting 1,000+ diseases before even they are diagnosed, just by common biomarkers, or not biomarkers, tests that exist in healthcare systems. So if we can take AI and general tests that exist, map it over with risks and genomics, I think, to your point, we can solve for the younger generation. But it is multifaceted. The challenges to learn from those, as Dr. Holland said, there are still opportunities to solve, but really looking at what's coming and leapfrog some of the areas.
We need a lot of big data to find small changes to get at the causes.
And I just want to double down on that, just to crystallize on what you said. The younger generation that we're talking about with this early onset, they're not eligible for cancer screening. That's not going to be covered by health insurance because the guidelines don't support it right now for the general population. So I think what you're hearing, or what you're saying, which I totally agree with, is we have to think differently and leverage innovation to address that specific population, which might be a very different set of gates than how we fix for people who have hit that age-eligible stage for cancer screening.
Yeah, and today, when a younger person gets diagnosed, they're either given, I'm so sorry you've got this diagnosis and it is so late that it is stage 4 or metastatic or whatever it is, or they're saying, you're lucky you found it incidentally. There is no way of screening them and getting diagnosed early. And those who find it incidentally, there are opportunities to actually ensure that we can accelerate incidental finding without increasing cost on a healthcare system, but the technology will play a huge role in really ensuring that we can leapfrog this.
Well, I want to turn to Amir Ali because your company, had made big news earlier this year with the FDA's approval of your blood-based colon cancer test. So I know there's a lot of optimism to these points that a test like that, it removes the ick factor from certainly a colonoscopy or any kind of stool-based tests. But tell us a little bit about, that was a couple of months ago, I know, that the FDA approval came through. So where are we at in terms of the rollout, and what kind of interest are you all starting to pick up on?
Yeah, sure. We are very excited with that development. Maybe initially I can share some of our findings in our pivotal study in terms of this, cancer incidence in youth. So I think probably the prospective cancer screening study we did in the field of colorectal is one of the most recent ones. It just finished in 2023. We look at about 40,000 patients, and the point that I want to highlight is the rate of advanced adenoma in young patients. In our study, it was 45 to 59. And advanced adenoma is a precancer to colorectal cancer, right? That rate was 11%. We used to see this level of advanced adenomas in much older patient population. So when we are talking about the rise in colorectal cancer in youth, most probably future is going to be worse before it gets better, based on what we are seeing in terms of these adenomas in the colon of the very young patient population. But maybe we can talk about why some of the young patient populations are not going through screening journey. There are multiple elements. I think the latest stat is patient age 45 to 49, about 20% of them are going through screening journey at this time, although the guidelines recommend it. I think multiple factor goes into it, like, in that age population, based on the lifestyle, what's going on, some of the time commitments, access to the current modalities. But the reality is, when you even want to go through colonoscopy, I don't know the national stats, but for instance, in California, sometimes you have to wait still 3 to 9 months in scheduling queue to go through the colonoscopy. We are at a level that colonoscopy is gold standard, but we are very close to the capacity of what we can do. So in fact, if we want to reduce the age of screening to even younger patient population, we are going to make this problem even harder. So then what's the solution? What we are excited about is acknowledging that the gold standard is colonoscopy. Everybody should do it if they have access, if they can do it. But the reality is giving a new choice to patient, especially young patient population, with a simple blood test that can integrate it routinely in the clinical care. Many patients see their doctors for many reasons, and blood testing is very routine. Just imagine with a simple blood test, you can screen not even just for colon cancer, for a bunch of other cancers. And in case you find some signatures in blood, for sure you have to reflect those patients to the next journey in terms of colonoscopies or imaging and so forth. So we are very excited about the technologies, and it's beyond our company. This is a field, this rate of innovation is very strong, and that future is here and now. And it would be good to figure out pathways for really these young patient population to get access to this innovative technologies.
I did have one particular follow-up question for you. As I understood it, your test had very impressive results, certainly compared to its predecessors. But the challenge remains in identifying at high rates, precancerous growths and early cancerous growths. I'm curious, what are the prospects for that, in terms of next generations of your tests, and what will be necessary to be able to develop that level of precision?
Yeah, to maybe give more details, our test really works very well for detecting cancer, but in terms of detecting the precancerous lesion that we talked about, advanced cancer, it's not a great test. The performance is very low with the current generation technology that we have. I think as we accumulate data, as the science progresses, there are potential pathways to see maybe down the road these tests over time could get better. But the problem we are trying to solve is there are 50 million people in the United States that needs to get screened and they remain unscreened. When we are looking at younger patient population, we need to offer them a menu of choices that they can actually pick instead of remaining unscreened. And if you can detect colorectal cancer at stage 1, 2, the latest stat I remember, it has 90% plus long-term survival rate. So yes, it's important to detect precancerous, but it's much better. It's also good to downstage cancers from stage 4, from stage 3 to stage 1 and 2.
Yeah, can I jump in on that?
Of course.
I agree completely, and I think it's really exciting to think about multimodal prevention strategies. I mean, we don't have that today, but that's clearly in the future as we have so many different tools. And I just want to plug. I mean, studying this is going to be a lot to learn about what early stage tumors really look like in the blood, what late stage tumors, how we interact with the healthcare system. And so this is exactly why we started the Cancer Screening Research Network. And so we'll be exactly trying to sort out some of these questions. So it's an exciting time.
Yeah, if I can add to that, we talk about driving off of innovation. I think that's key. I think we have to rethink how we apply innovation, because traditionally or historically, we kind of do it in silos. Like someone is going to work on the best assay for colon cancer. Someone else is going to work on how to communicate about the need for this. And then the payers are really interesting, picking up on Karen's point. So I've spent a good deal of my career on the payer side before coming to City of Hope about 11 years ago. The standards that the payers will likely have on this is not just did the test work, not just did it detect cancer, not just did it detect early stage cancer. They're going to wait for the data to show did it preserve life. Yeah. And we as a society have to figure out, taking into account the cost, the impact of false positives, the psychological benefits, and also the psychological harm we can cause. We have to cross some of those silos and work together. And I think in this case, we have to agree on what we're trying to achieve. And then the payers and the researchers and the clinicians and the people who are doing the data analytics and creating the AI, we all have to work together to that endpoint. Otherwise, we're going to be in conflict. There's going to be great discoveries. People won't pay for it. People out in the community won't get it. This is an important topic, and it's going to be expensive. We're not talking about the 0.5% of patients who get cancer every year. We're talking about screening 300 million people, maybe not pre-adolescents, but close to 300 million people a year. There's a cost to the test. They're not cheap. They have false positives. That's not cheap. We're going to have to figure out collectively how we deal with all those issues.
Yeah, I think that's I couldn't agree with you more, Harlan, that we have to be very intentional about the use cases. And, Amir, you talked about the very significant delay in getting colonoscopy, even sometimes for people who are symptomatic in urban and rural areas across America. So thinking differently about how to use innovation to determine who actually is at significantly higher risk. Maybe they have colorectal cancer right now. We really have to find a way to escalate that person to colonoscopy is a really fantastic use case. And when you think about this rise in early stage cancer or early onset cancer, breast cancer figures really prominently in here. So I think there's a use case where this kind of technology could be really fantastic. So we've recently come to the knowledge that for women who are starting mammograms, sometimes at age 40, perfectly within guideline, women who have dense breasts don't know it, right? It's nothing you can touch or feel or sense. Your provider can't touch or feel or sense it. You really only see it on imaging. And we know for a woman who has dense breasts that she has a higher risk of developing breast cancer. And at the same time, it's harder to image. And so while we have now government regulation to inform women for the first time this year, you have dense breasts, therefore you may be at higher risk, and we need to start thinking differently about you. It's the thinking differently about you that we have not been able to solve for. You don't want to send this woman to mammography every 6 months because there is some inherent harm in mammography, right? It does give radiation exposure. So what could happen? So this is a perfect use case, if I were waving a magic wand, of what is the technology of a woman-diagnosed young woman who you want to limit radiation exposure to, diagnosed with having dense breast tissue, has not yet come up with an image of what looks like breast cancer. Could we use something like a liquid biopsy? Can we use something to determine whether or not she's got an early stage cancer that could be managed, and we really need to think differently about her imaging. And why I also bring up breast cancer as a use case is this rise in early onset breast cancer is almost invariably estrogen receptor positive. And I bring that up because we have very good chemoprevention strategies for estrogen receptor positive breast cancer. So let me pull it all through. 40-year-old woman comes in, it's her initial baseline mammogram. She's told she has dense breast tissue. She's now a higher risk for breast cancer for the entirety of her life. She takes, said to be unknown, liquid biopsy test. It says, it looks like you could be developing some early stage cancer. We can't image it yet. What are we going to do for her? Ask her about chemoprevention, which less than 1% of women currently take, but this would provide women a real reason to know that they should go on chemoprevention for breast cancer. So that's my magic wand use case, and I think that's where innovation is coming, and it's the kind of thing that's going to happen if we're going to address this early onset cancer.
Karen, can I insert one thing in your magic
I
wand?
love my magic wand. Yeah, go.
Because this is the data that you all published and your researchers published, and I want to throw this fact out there that black women in this country are 50 times more have a chance to die of breast cancer than their equivalent white women. And then if they are under 40, it's double. So if in this magic wand we can also address racial go into areas where we find those black women and really do cultural-based screening to bring them along with the patient navigators and ambassadors whom they trust at community level, this magic wand could do wonders in terms of transforming outcomes for these younger women who today don't have access to screening, or different barriers come in and technology could be different and could get on chemoprevention. So yes, there's a lot to add, but definitely I think we need to add the health disparities that come in because of other nuances that exist.
Well, Mohit, I wanted to...
There's more to add to the magic wand.
Well, I wanted to come to you anyway because we have appropriately, I think, spent the first half of this conversation talking about prevention and screening, how to get ahead of problems. But I don't want to lose sight of treatment, which is obviously sort of your company's particular area of expertise. And so I wanted to give you the floor to brag. It's an exciting new era. We've got immunotherapy has obviously been various immunotherapies have been in the work for a while. I know there's a lot of excitement about what could happen there. We do, through new technologies, have an ability to attempt to genetically target treatments in a way that we weren't able to in the past. What's coming down the pipeline that particularly could be helpful with the increases in, or the cancers where we're seeing increases among young people? And I'm particularly interested in how you all might be using AI to try to identify promising drug candidates.
Yeah, I can talk for hours. I promise this would not be bragging about AstraZeneca. This would be bragging about where the science is going, right? The power of science. And if you think about where we are focused, if you think about where we are focused, is we are trying to really imagine, all of us here, along with the ecosystem, that can we get to a point where we can eliminate cancer as a cause of death, leading cause of death, right? And to do that, there are approaches from treatment which we are focused on in really looking at how we are targeting cancer cells directly, understanding the genetics, the drivers, and trying to find ways and modalities to switch those off and intervene using biomarker testing, engaging at community level, bringing interventions at the right time. But also harnessing the power of immune system, where your immune system is able to detect and almost kill those cancer cells, or actually keep them keep them from growing further, right? That's it. But the combinations is what is going to drive deeper care and deeper durable responses. The beauty of this is, as you talk about younger populations and you combine that with identifying them early. So here you've got someone who's got a longer life left to live with the challenge of cancer, but is detected early. So you can intervene early with treatments that don't have to last long, treatments that is harnessing their immune system so that they are taking over versus the medicines helping them in the longer run. And actually, so the promise of that, the new things like cell therapies, where we are really getting into, using their own cells and genetically altering them and really equipping them to deal with cancer in the longer run and drive cure, is the promise of science. And I think science goes all the way from prevention, right? Really understanding what we can do and intervene there, early detection, biomarker testing, where we are driving who is eligible for what based on what their cancer is, and then really personalized treatments that help them get cancer in control and live longer with a survivor. And I think Karen wrote this in one of the, you write everywhere, so I have to see where it was, that there's a tsunami of young survivors coming, and their needs are going to be very, very different. So thus thinking about treatments that help them live their life to the fullest is really critical, but also really ensuring that we are continuously addressing early populations, younger population, but metastatic populations as well, because these cancers will come back, and we need the science to constantly be smarter than the cancer that is constantly also very smart in terms of finding new ways. So,
well, Cameron, I know that this issue of sort of young survivors has been a preoccupation of your all's at NCI. And, in my life, I have a friend who's a breast cancer survivor in her mid-30s.
Yeah.
And so I'm curious, what are we learning about how to treat those patients and to sort of provide for them and care for them, both obviously in the acute phases of their disease, but then afterward? Like what unique challenges do young survivors present, and how are we going to address it?
I'm glad we got to survivorship, because I think this is where there will be an incredible amount of science to learn how we do really good survivorship or post-cancer care for people, as you said, who have a long life to live afterwards. But the issues that we have talked about in survivorship for a long time are just amplified in this age group. And then some of them are unique, things around fertility, sexuality, family dynamics, the emergence of independence for people who are just in that early phases of becoming financially secure. To have a devastating cancer diagnosis can change all of that. So I think it gets beyond what our drugs have done to cause cardiac risk and risk for metabolic disease and changes to your immune system. Those are all absolutely true and will be different as we look in people who are post a cancer treatment at 20 years and 30 years and 40 years, as well as some of the other factors as well that allow someone to have a productively healthy life. And I think we can't forget that someone who has a cancer at 20 might have another cancer for many various reasons, just simply because there are many more years of opportunity. And so being able to this is where working across different cancers is going to be very important as well.
That's exactly right? Someone who has a cancer diagnosis is much more likely to get a second cancer diagnosis of a different cancer type through their lifetime.
Yeah.
So I want to just pick up on a few things. So I think you covered the topic amazingly well, so I don't have anything to add except just we talked about genetic testing and making sure family members are tested as well, which can have a great impact if you apply the right measures. We talked about the psychological impact, but I want to just step back and talk about how we in the community deal with survivorship, because right now you have a bunch of folks that are MDs and scientists. We're in the mood, we understand what we mean by survivorship. But out in the world, managed care industry is thinking about survivorship of what's the schedule of how many mammograms you need to have over the next few years. They're not thinking about all the issues that you just mentioned, Kimberly, and there's not going to be coverage for all those issues. But you take away the invulnerability of a 30-year-old, it changes their life in ways that we really haven't studied very well. So we need to focus on that, on these issues. It's very important that we do. The other thing to remember also is everyone, I want to believe it too, that the health system all knows what we're doing, and no matter who you go to, you're talking to an expert. This falls into a nexus. Cancer doctors are typically not taking care, the major cancer centers we do, but cancer patients usually go back to their primary care doctor. So primary care doctors really aren't aware of all the things we're talking about today. I would even say, we've been talking about multi-cancer early detection. We just haven't used that term. Those are the blood tests. Most primary care doctors have no idea what it is, and those that do know don't really know what the statistics mean, and then some don't even know what to do with a positive signal. This is a new area. Young people with cancer is a new area. We talked about treatments. We know that for the same cancer, pediatric regimens are sometimes more effective than adult regimens. What do you do with a 28-year-old? Is that an adult or a child? So we need to study that, and we will. You asked about immuno-oncology. We have experts in the room, but I think it's lymphoma. The outcomes in the pediatric regimens were so much better than adult. So, well, let's try that. But then by adding immuno-oncology to the adult regimen, you equalize the survival. So this is a dynamic and difficult field, and we don't have an area of medicine that's expert to deal with it. We got to study it. We have to think about training our medical students differently so they're more aware of this. I do want to just take 30 seconds to answer the question that you asked about what's exciting out there. The changes in oncology in the last 10 years have been remarkable. You talked about it. We can take the cells in a human body, genetically re-engineer them and put them back into the body specifically targeted to the cancer. I mean, that's just remarkable that we can do that. But in addition, we can take antibodies that are partly going after the cancer and partly now carrying chemotherapy or some other oncolytic, and then deliver it directly to the patient. I mean, I can go on, and we can take the blood, the white cells that kill cancer directly out of a tumor, grow them outside, and then because they're in the tumor, we know they're there to fight the tumor, re-inject them several weeks later after we've grown them. That's TILS therapy. So we have NK, CAR, BMT. The world of treatment, these are usually targeted to liquid tumors like leukemia, lymphoma, but all of us have studies going on right now to address solid tumors. I think when we talk about the young people with children, some of them are appearing to be very aggressive, like colon cancer, not children, and young adults. Mm-hmm. They tend to be aggressive. We're going to have an aggressive armamentarium of drugs, and I'm excited about what we're developing in our labs today.
I want to highlight, if I may, about the role of guideline bodies. Like, we are talking a lot about a bunch of exciting innovation, exciting kind of development or changes which is happening in the field of oncology for cancer survivors or even early detection. And when we think about, for instance, for cancer patients, when a new therapeutics gets to good outcome in terms of clinical studies, regulatory approval, then guideline bodies actually typically try to have living documents to incorporate those kind of innovation changes in their recommendation, and then that would take care of typically the last mile of accessibility for patients to get access to those innovations. However, when we are talking about prevention of secondary cancers in cancer survivors, when we are talking about prevention of even the primary cancers in young patient population, in the United States, all the preventative services measures and recommendation goes through a task force called the United States Preventative Services Task Force, USPSTF. And it's amazing for us when we studied that during the last few years. They are so underfunded that their cycle of review is every 5 to 7 years. If there are any kind of, let's say, we understand even in youth patient population, colon cancer looks like some epigenomics is changing in their colon. We don't understand why, but maybe even a therapeutic can reprogram it. If there are screening tests that can detect, this disease at early stage, for the patient to get access to those, everybody's going to wait for USPSTF. Great volunteering team, but the process is 5 to 7 years. And it's not rigorous scientific review. It's just they don't have bandwidth to look at the latest advancements. So we need to figure out how to make improvement in this last mile of accessibility. And kudos to American Cancer Society by really having living guidelines to really pave the path for some. But the reality till we don't do a better job on the task force, many young patient population would not get access to these innovations that we are talking about here.
It's a huge investment to do a guideline study. Even for us, we're in the process of doing our new prostate cancer guideline study. It's been ages since ACS had done it. So even we are not on the fast-paced cycle I'd like us to be because of the magnitude of work involved. But we do tend to lead and hopefully guide the U.S. Prevention Services Task Force to some areas that we're thinking about. We get asked frequently, should we look earlier for even colorectal cancer? Yes, we dropped it 50 to 45. Do we need to look younger? We're looking at that. We're also looking within populations where there is a younger onset and looking at demographics and geographics to say, well, what's different? If we think about the women who are getting breast cancer at this earlier age, there are subgroups within there that are even much more striking on an escalation path in the United States. Women of Asian American and Pacific Islander descent, a group that we normally thought of as being, having less of a propensity to develop breast cancer. So there's something more in there. It's even beyond just the screening for everyone. It's really understanding what demographics and geographies are being most impacted and why. And even before you got a screening guideline change, to Mohit's point, what can you achieve through community engagement, awareness at the level of a primary care physician who doesn't turn away someone who's symptomatic just because they happen to be 39 years old instead of 50. I think there are things that we can do right now that complement guideline changes. I'm with you. I want them to be faster too. I want everyone to know their genetic risk. But until we achieve that magic wand milestone, what else can we do, I think, is the way we kind of align our priorities.
I want to talk about the bias in some of these guidelines too, and get to picking up on Mohit's example of breast cancer. The incidence of breast cancer in Black women is actually 4% less, but their death is, what is it?
8% less.
8% less.
But the mortality is?
I'm done. It's 40% higher.
Yes. Exactly.
So, but going back to the U.S. Preventive Services Task Force, first time I've ever said that correctly, by the way. Years ago, they used to recommend a test called the PSA, and that was for prostate cancer. And then they took it off the firm recommendation and said, talk about it with your doctor. It's because across the large population, it creates more false positives than actually finding cancer, and then also prostate cancer is slow growing. But in a Black population, prostate cancer is, PSAs are really effective at catching it earlier, and they die at 100% higher rate from their prostate cancer. So to get to the point, you need to focus on the cohorts, we need to focus on genetics, and the next rounds of guidelines for prevention really do need to be more precise. Otherwise, we're going to underclub in certain areas, which is going to lead to more cancer, and then we're going to overclub, which is going to cause a lot of worry and financial risk. But that's where the science is so exciting. Like we didn't understand this 5 or more years ago when I was in med school. I mean, but we've now gotten so much more precise. We just need to apply it, and we need to make, as a society, we need to make investments in the research.
Dylan, if you may, I think one of the view we are missing here is the patient view, the individual who goes through it. And I can't go back home without saying this because my wife would kill me for that. She's a cancer survivor. She's a 5-year, she has multiple myeloma, she's cancer-free, doing very well. Detected at the age of 34. So when you said it, you're young, you're interested in it, it is personal for me too. And I feel that across her journey, while having all this knowledge, being in this field, every now and then, it was very clear we have no idea what these people need. And this is where that comment on the tsunami is coming is true. Like all the way from fertility, all the way from what their future other health challenges are. When they travel, what kind of insurance will cover me and not? How do I go for scan? Oh, another abdominal pain. Oh my gosh, I need a CT because another cancer could be coming back. Every day they live very differently, and they don't have a support mechanism. Yeah. Multiple myeloma is found in 65 plus, right? Where's a younger person she can talk to?
Yeah.
So there are so many other things. And again, this was found incidentally. What can we do better in all the things we have talked? How can we support them? How can we take care of the gaps that exist? There's so much in there. And this is where, last thing I'll say is, maybe we talked about this in a lighter vein that we don't want this to a dinner conversation. I think this should be a dinner conversation. We need to break the stigma of cancer, because right now, what was science fiction is becoming science reality in a clinic next door. If we can educate the society, if we can remove the stigma around the C word, if we can understand and impart knowledge on what are risk factors, what we know today we can prevent, how do we get ahead and talk to our physicians and get on this, how we solve the infrastructure challenges, I think we can move the needle forward. Treatments would only add to it. This itself will solve a lot of the challenges that we have.
Yeah. Well, I want to get to some of the great questions that have come in from our audience, but I feel obliged to ask one last one of my own of you, Kimran, which is there was, as some people may know, a presidential election recently, and we're going to have a new administration and a new Congress next year. And as I'm sure you're aware, further NIH cuts have been openly discussed as a possibility under that new administration and Congress. what would that mean for the prospects for cancer research? And more broadly, how do you all start to win back what used to be a bipartisan consensus around medical research?
Yeah, so the first thing that I'll say is I think there still is bipartisan support for cancer research. I've seen that in every communication conversation that I've had. So I think that we'll continue to be receiving support in that way. You know, when I talk to members of Congress, I try to make it clear, number one, the amount of money that's invested in the NIH is the best return on investment that the government can really make. The impact for human health, for the economy, for our workforce, it's actually tremendously underfunded currently for what it is that we want to do, especially with the new therapies that are the new discoveries. Many will move into the commercial sector, but they start at NIH research. So I think it is really incumbent on us to be clear, to be communicating. This is not just for us talking to the people who are appropriators, but people need to be talking about how important it is that we are doing this research. We just talked about a lot of studies that need to be done that none of us want to have take 10 or 20 years until we get to the place where we can say, yes, we're doing this right for young people with breast cancer, colon cancer, gastric cancer, any of these rising cancers. So we need to be vocal, clear, and know where that kind of research can have a big impact. So yes, we're talking a lot, but we have been before. So this is our sweet spot, is to help people understand why this is so valuable.
All right, well, I'd like to, there's a couple questions on subjects that you all have been already discussing that I want to bring us back to. One is about provider education. You just made a reference to the scenario none of us wants to see, that somebody talks to their doctor and their doctor either doesn't see the warning signs or doesn't take it seriously because of their age. So either you, Harlan, or any of you, I'm curious, what are we doing for provider education? And how are we making sure both that they are just aware of the general trends and what to watch for, but also of, as clinical guidelines are updated, how are we making sure that they're aware of those?
Tag team quickly on this one. So one of the things, and I'm also a former healthcare person leading one of the major cancer centers in the US. It's the case that we use at the American Cancer Society something called Project ECHO, which was actually developed at one of the other major cancer centers, actually in New Mexico, which is a way to get information out to primary care across large geographies. If you think about New Mexico, they've got to do that. And so it's an intentional way that you train and echo a new concept for implementation to primary care physicians. So we have Project ECHO around some of these new findings about the rise in cancer in the younger population, so that there is a true awareness. It's one of the things that we continue to do. I'm also aware that there's some pretty innovative things at places like Duke, where they have a special certification program for primary care physicians to ensure that they have the specialized training to see people who come out of the survivor tsunami, who are cancer survivors or who are seeing someone who is early onset cancer. Those are two of the things that come to mind.
Yeah, so I'll build on that. I think Karen's done a great job talking about what we can do with primary care. I'm going to focus on oncology care. So just two things, picking up on your wife's journey, and I'm so grateful to hear that she's doing well. There's a huge gap in supportive care medicine, and there's a lot of coalitions that are trying to address that. But here's an interesting stat. We did a survey. About 80% of oncologists say they provide supportive care services to their patients, and about 26% of patients said that they received supportive care. So there's education needs to take place just on supportive care. But here is the other area where I think we need to reform or reimagine how we structure our networks of oncologists. 30 years ago, there was, I would say, a lot of camaraderie between the community practice and the academic centers. The way things are set up with networks now, and narrow networks in insurance companies, there's a bit of a pitting of the community doctor against the academic doctor. And here's why it's relevant to what we're talking about today. A lot of the science may start in NIH labs like Garden, AstraZeneca, but also in academic centers. And then the practical use of these are absolutely starting in the major academic centers or the NCI centers. And the inconvenient truth is that outcomes are better at major cancer centers. And by creating this separation competitively from a business point of view, I think in the 30 years or 35 years I've been a physician, there's a decrease in communication between the community network and the academics. And I think what we need to do is create new ecosystems where the economics are set up where patients can seamlessly move to the academic center when they need something, a clinical trial, advanced therapy, a complex case. But by the same token, we're pushing patients who are not as complicated or have a set plan back into the community where they can get their care closer to home, surrounded by loved ones. When you create that ecosystem, all the great things we're talking about here get diffused into the environment faster, as opposed to this artificial divide that we have today. So I think you dealt with primary care. I'm talking even within the oncology network, there's a gap and a fall off in knowledge, and we have to bridge that gap. And I think creating a new ecosystem of cooperation is the only way to do that.
Yeah, actually, if I can jump in and take that just one step further, I completely agree that we know that 80+% of people get their cancer care in communities. And so if I could have I forgot your
Magic
wand. If I could have
Sure.
my magic wand, thank you. It would be that every patient who lives a good distance from an academic center or that's not their primary place has a dyad of doctors. We have telehealth, we have ways to make your vision a reality so that they can have their local doctor, they can have access into the academic center. I would love to make that be a place where we do research in that kind of a cooperative way as well. So there you go.
We completely agree. And it started with City of Hope, but there's now 7 NCI centers that have done this. We created a company that is now independent, which does exactly what you just said. The company is called Access Hope. The services are purchased usually by the employer, sometimes the health plan, and it does exactly that. It takes the data that's coming into a health plan on newly diagnosed or changing cancer patients, and it puts it through an algorithm. It identifies the complex cases, and then it sets up a subspecialist at one of these 7 NCI centers to actually write a report and be willing to get on the phone and talk to these doctors. The patients don't leave the community. They get this, it's the dyad that you're talking about, and it's not just cancer evolves. It's not a one-time interaction. It's a partnership that we're creating. So those models are out there. I mean, we think we should, your vision is exact. I'm going to hand the wand back to you. No cancer patient should end up seeing a doctor that's not fully informed about the best or optimal treatment. And in reality, that's what's happening today.
That's right.
So this dyad model that you set up is what we need, and we're hoping Access Hope, we actually talk about, we hope Access Hope will get competitors because we want everyone to match up a local community doctor who, by the way, is doing a great job, but the knowledge is doubling every 72 days right now, so no human being can keep up.
Yep.
They need partnership with physician leaders in that specific cancer type, and that's what I think we need to aim for in the future.
I'd want to get in one more question, and I'm mindful of the time. And Mohit, this is probably a question for you or you, Amir Ali, but I want to take us to the other end of the pipeline. There's a question from the audience about the importance of phase 1 clinical trials and clinical design, or clinical trial design in general, which I know is an ongoing challenge between sufficient scale, sufficient speed, the right demographic makeup, et cetera. So to use this magic wand one last time, if I were to hand it to you all who are really in the development field, what would you all like to see in terms of how we might achieve those goals with clinical trials?
I think clinical trials are absolutely important, right? Today, only in great centers, 5 to 7% of their population gets into trials. In community centers where care happens for majority of the patients and where the gap starts to increase, less than 2% of those get into clinical trials. So if we can get right infrastructure set up to take clinical trials everywhere and really get them embedded in communities where eventually patients are treated, along with partnership with academia, that's what will move the needle. By the way, that would also get us diverse patient populations into our trials. That would show how a drug or a therapeutic intervention works in different kinds of population. Today, that's not the data we have. So this is something we are, as AstraZeneca, investing, other companies are investing to really ensure that we are able to take trials where real patients are, where whom we are intending to serve as part of the US Census.
Equitable, patient-centric clinical trial with strong private-public partnerships. I think that would be the future, and the future we need.
Got it. Well, thank you so much to our panelists. Thank you to our audience.
Thank you all.
Yeah, thank you.